Hi, welcome everyone. My name is Linda Schwimmer. Good afternoon. I'm the president and CEO of the New Jersey Healthcare Quality Institute, and it's wonderful to have you all with us today to discuss the case for increasing our investment in high quality primary care. First, I want to start with a few housekeeping items and formal items. I want to thank the New Jersey Academy of Family Physicians and the Robert Wood Johnson Foundation for providing support today for this conference. Also, note that your lines are all muted for the duration of the conference to reduce background noises, but we do want you to participate. We are going to have plenty of time for questions at the end of the keynote and the two panels today. So please put your questions in the chat box. And if you prefer to ask them verbally, you can raise your hand and one of our staffers will assist with unmuting your line so you can ask your question. I also am excited to see Chris Kohler here on the screen with me, and I'm going to be introducing him in a moment. Just to frame today's conversation with all of you. Oh, wait, and I also want to let you know that we are recording this, and so it will be available on our website, and we will send it out to all of the participants as well. And to get back to the framing, back in April of 2021, the Quality Institute, along with BioNJ and many of you, released a paper called Emerging from COVID-19, an Action Plan for a Healthier State. And in that paper, we included 3 specific recommendations for strengthening patient access and connectivity to high quality primary care. We know that a strong connection to primary care improves patient outcomes, overall population health, and increases equity. That is why we chose to then create this 2-part conference, and we are now focusing on part 2 today. Back in December, we had the privilege of having Shauna Hudson, a professor from Rutgers University, and one of Chris's co-authors in a recent paper released by the National Academy of Science, Engineering, and Medicine, discuss the value of primary care in increasing equity. And we also had other panelists that gave examples of unique types of primary care. For today, we are having Mr. Kohler and the other panelists discuss how to support those models and how to increase the investment in primary care and to track that investment. So sort of the how-to discussion today. So we're looking forward to that. And this discussion is quite timely because this year we have a requirement in law in New Jersey where both our Medicaid, Office of Medicaid, as well as our Division of Pension and Benefits have the requirement of tracking and reporting on their investment in primary care. So we're looking forward to discussing ways that they can do that and how to support them in those efforts. And now, without much further ado, I want to introduce our keynote speaker, Chris Kohler. Mr. Kohler is president of the Milbank Memorial Fund, a 114-year operating foundation that improves population health by connecting leaders with the best information and experience. Before joining the fund, Chris served the state of Rhode Island as the country's first health insurance commissioner, an appointment he held from 2005 to 13. Under his leadership, the Rhode Island Office of Health Insurance Commissioner was nationally recognized for its rate review process and its efforts to use insurance regulation to promote payment reform, primary care revitalization, and delivery system transformation. And I greatly respect that as a former insurance commissioner. That's wonderful. Mr. Kohler has a bachelor's degree from Dartmouth College and master's degrees in social ethics and public-private management from Yale University. Welcome, Chris, and thank you for being here. And I look forward to your keynote and our discussion thereafter.
Thanks a lot, Linda. And I am going to share my slides, which Tyler told me I could do. Let me make sure everyone can see. Slideshow start. Okay, are you seeing the full screen?
I am.
All right, you're the only one I can see on the side, so I gotta make sure I'm all right. So thanks very much, Linda, for the opportunity to speak with you folks, and to all you folks for turning in on this. You'd heard about the Milbank Memorial Fund. This is just our opening slide to describe what they do. I want to acknowledge the contributions here to this work and this presentation from Lisa Dulski-Watkins, the program officer at the fund, who's on the call today and really does all the work that you'll see described here in terms of our work with different states. The other thing is, I'm not a clinician, but you're supposed to give your disclosures. So I am on the advisory board of the Center for State Health Policy at Rutgers. As near as Margaret Kohler and I can figure out, we are not distant cousins, but sometimes we use that line since there's so few Kohlers that are around. What I want to talk about is the case for primary care as a common good, the NASEM report recommendations, the implications of the budget language that Linda was talking about, and then really focus on some lessons learned from other states as you do this work in New Jersey. You heard from Dr. Hudson about the implementing high quality primary care work that the NASEM committee released. I just want to ground ourselves in that and note what a privilege it was to work with Shauna and others on this. This is the kind of primary care that we're talking about. It was one that's delivered by interprofessional teams. There is a notion of accountability. It is delivered across settings, not just from 1 to 5 in the afternoon when the doctor's in the office. And it's delivered through sustained relationships with patients, families, and the community. So that's, when we talk about primary care, this is the primary care that we're aspiring for. This is kind of the pitch that I think those and all of us realize, but this is documented in the NASEM report, and I think those of us who work on primary care would do well to make sure this is, when we talk about it, this is why it's important. It is the only part of the healthcare system where an increased presence is associated with longer lives and more equity. No other part of the health system can say that areas with more primary care per capita and relative to specialists have longer lifespans, and that those areas have lower rates of disparity. No other part of the delivery system can make that claim. That's why we think it's important. It's also, as the NASEM report says, important to note that it is weakening in the US just when it is needed most. We did this report in the time of the pandemic, and yet the portion of healthcare spending that's going to primary care in the US is small, and it's decreasing. And this is at a time of increasing inequity, and as we talked about, low pandemic resilience. And finally, in the long run, a primary care system is less expensive, but that is not the basis for why we ought to be paying attention to primary care. We think these first two goals are the important ones, that you should not make the case for promoting more primary care as a short-term cost savings. We don't ask that for other parts of our healthcare services, and they don't improve equity or increase lifespan. Key to the NASEM report, and Dr. Hudson probably talked about this, is this notion of the common good. That means, or a common good. A common good is one where all have access to it, and we've decreed that in the United States. We don't let emergency rooms turn away people when they show up, but you have a limited supply. So more for you means less for me. Education is an example of a common good. We think it's important to frame primary care this way, as opposed to just it's one more service competing with a bunch of other healthcare services, because no other healthcare service can make the claims that primary care can around lifespan and equity. And so if you think of it as just another service, then access and scarcity are addressed by the market, and primary care is too important to look at it that way. But common goods require public policy to steward. We're not going to innovate our way to high quality primary care for all. These have to be public policy choices that we make. The NASEM report had these 5 areas, and I'm going to focus on the first one, the payment. But we work hard to craft these messages in ways that were sort of capture what we were talking about and also might stick in people's minds. To pay for primary care teams to care for people, not individual doctors to deliver services. to ensure that high quality primary care is available to every individual and every family and every community, to train teams where people live and work, to have information technology that serves the patient and the family and the care team in that order, and then to have accountability to ensure that primary care is implemented across the United States. The payment piece, which is what we're really going to focus on, are these 4 actions that the committee recommended. The value and the importance of primary care payment is its ability to deliver high quality primary care, not because it's going to save money in the short term. We think that as a first step, you've got to get off fee-for-service and do hybrid reimbursement models. We think Medicare has particular responsibility because they are so big and all other payers work off of how Medicare pays primary care. And so CMS has to value primary care more. And then what we're going to talk about today is the importance of multi-payer collaboration and increasing the portion of healthcare spending that's going to primary care and the role of states in leading that work. As Linda said, the New Jersey budget language, which was really great that you guys got in there, focuses on where the state has the most levers, which is Medicaid and public employees. And it requires those 2 areas of state government to collect and publish primary care spend information by carrier. It also requires the Office of the Treasurer to conduct a market scan of state-funded based primary care models and then to publish those findings. You do this because relative to your neighbors, you're even within a country with weak primary care orientation, your primary care orientation is relatively less. This is data from the Commonwealth Fund that we've worked to have them published that notes the portion of primary care spending among Medicare beneficiaries. We focus on that because the data on there is particularly good, and the portion that's going to it. And I think Sean Kavanaugh is going to speak to, in general, the role of primary care in Medicare later on in this session. And another way to measure primary care access is patients who report not having a personal care doctor or healthcare provider. That's a function of ability to get to primary care and also insurance access. And even with Medicaid expansion, you are 1 in 6 people in Rhode Island do not have report not having access to a usual source of care. That's a cause for concern, I think, for you folks. And frankly, across the country, it's 1 in 5. And note the disparities based on race and ethnicity. That's just morally not acceptable. And it's a reason to work on strengthening our primary care infrastructure. So what have we learned from other states that have done this? And I want to just first of all note, you are not alone in doing this work. Some states have set primary care investment targets, in some cases with a enforcement mechanism through their commercial insurers or through some sort of performance improvement plan. And then we have others, we have all these states that are contemplating or have done initial reporting and are following that up with additional state action. There really is a lot of movement going on. And I would note the second group, they're not only contemplating, they just haven't they're doing more than contemplating, they're measuring, they just haven't put specific targets that are out there. But what have we learned from these states so far? The first thing is to keep your goals clear, to keep it simple, stupid. Our goal is to put more money into primary care and to pay for it in non-fee-for-service ways. Everything else that we can get, frankly, wrapped around an axle about, what is the best kind of primary care? How do we measure it? How do we pay for it? Is secondary to the primary goal of putting more money into primary care without increasing overall insurance premiums. Let's name it. This is a redistribution that's going on here. And this is examples of how we did it in Rhode Island in commercial health insurance with improvement in that primary care measure over time for the commercial health plans operating in Rhode Island. The second lesson is the more payer types you have in this process, the better, because we know primary care teams see people with all different sorts of insurance coverage. And if I'm a physician, a provider team, primary care team, and I see 10% of my revenue go up by 2%, 2 percentage points, that's not really going to move me very much. You have to get to the majority of revenues that are affecting primary care practice if you want to make a difference. The third is that we have to measure regularly, as performance improvement people will tell us. You only improve what you measure. You have to do it publicly, and you have to name the payers. by far the best example in the country is what the Oregon Health Authority does, where they're putting annual measures of primary care spend by payer, setting them against a target so they can see performance over time. We think that's really important, and it's to develop that capacity at the state level. And then the fourth lesson that we've taken from other states is to have a state convened table to build alignment and political will. And the example that we have is from Colorado. Colorado has specific legislation given to the insurance commissioner that establishes a primary care payment reform collaborative that the Department of Insurance runs. And Kate Harris is going to talk about that today. These are all the charges that is given to that table. It continues on the next page. It's the place where the primary care spend measure gets reported. It's where people talk about what the target should be and how that money should be spent. These second order challenges of, okay, we're focusing on primary care. What do you want to work on? It's also how, frankly, you build political will for primary care in a what is a very competitive environment. You have to build this public voice for this notion of primary care as a common good. And we think that these tables that are convened by the state are, or if you will, if not convened, at least commissioned by the state, are important ways to do that. So what are some of the challenges and opportunities for New Jersey? The first is to really be clear about the problem you're trying to solve. I think it is the dollars. I think the notion of the perfect payment model, the perfect care model, the supply of physicians is all secondary to money. The second issue is there state government capacity and will to attend to this public good? You got this language slipped in there through the budget. How can you expand upon it? The third is you already have, and we are involved with this, the governor's cost growth affordability work group. And as you develop this, both of you are looking at total dollars and total dollar spend. We love working with Shabnam. And how do you link this primary care work to that notion that basically says we have a certain amount of dollars and we want more here and less here. And so it's important, just from I'll say as a state official, not to get too many irons in the fire. You want to have things that are linked to one another. And then finally, in New Jersey, your particular challenge is getting to multi-payer impact. Medicaid and public employees is a great place to start, but that's not anywhere near a plurality of revenues for the typical primary care practice. So you've got to move more dollars into that primary care spend measurement and primary care spend target. Where I want to end is just, lest we lose, and this is sort of, Linda, I appreciate you sort of talking about the origins of this, just to remind ourselves about the importance of this work. We were privileged to be able to publish information coming from Maryland, which has been involved in multi-payer primary care transformation done in partnership with Medicare for several years now. As a result of building up primary care capacity, increasing their primary care spend, they've been able to develop a state-supported transformation program that was able to link to their public health program during the pandemic. And so what you see here is a measure of how their primary care practices that were being supported in this multi-payer way with increased investments with a connection to public health did on COVID compared to those primary care teams that were not linked to it. These might look like small numbers, but I want you to get to the bottom one, the percentage with COVID death. This is the percentage of the panel. You know, you're talking about 0.41 as a percent as opposed to 0.5. That may not seem like big numbers. That's a 20% difference. That's 200 fewer deaths for every 1,000 people in COVID. And we can get that with a primary care investment. That's 200 people who lived in Maryland who would have died if they didn't have that access to primary care. I hope that gives us a sense of why this work is important and why it's really great that you folks in New Jersey are coming together to think about this. So with that, I'll stop. And I think, Linda, we're gonna have a little bit of a conversation, and I gotta remember to stop the share. Thank you.
Yeah, absolutely. Thank you. Thank you, Chris, for your rapid fire advice on how to get to where we need to get to, and also to really creating that context for us of where New Jersey currently is, and your diagnosis that it's It's really that we are unfortunately underspending on this comprehensive primary care that we're talking about. I have a lot of questions, but I want to follow up on one of the questions we just got in our Q&A because it really directly relates to your very last point on why this is so critical. The question is, are there opportunities to increase investment and collaboration between primary care and public health? We discussed that a lot in our paper, but I would love to hear your thoughts on that, just the connectivity between this opportunity to invest more in the public health issues around it.
Well, thank you, Linda. I think anyone interested in public health is aware of just sort of the magnitude of order difference in our spending on healthcare services as opposed to public health. And what I think of as primary care investment is it's almost creating a receptor site for public health work, or sort of a partnership. And you find that this is what you saw in Maryland. It's what I heard stories of among my colleagues in Rhode Island, where we're based, is that when you have a strong and organized primary care infrastructure, you almost have a dissemination vehicle for the public health work that you want to do. You have partners for public health to work with. It's why public health in some areas runs its own primary care clinics. It becomes a responsibility of public health. But I think we need to go broader than that, especially depending in parts of the country that don't have that public health clinic capacity, which typically is devoted to low-income folks. So I think absolutely an investment in primary care is an investment in public health, because you're developing the capacity to disseminate whatever it is the public health work that you want to do, whether it's around immunizations, whether it's around pandemic messaging, pandemic treatment, things like that.
Great, thank you for that. So I was hoping you could describe a little bit more, in more specifics, how Milbank is involved in states seeking to increase their investment in primary care. What is the role of the foundation, and how are you working with states, including ours? You mentioned Shabnam Saleh, who we are lucky to have running our Office of Healthcare Transparency and Affordability. Maybe you could just, for those who don't know about the work, share some details.
So our mission is to improve population health by connecting leaders and decision makers with the best evidence and experience. We think there's a lot of evidence and experience around primary care. And so our work that Lisa Watkins, really falls into two big buckets. One is doing exactly this, helping states think about primary care spend as an organizing principle, as a way of measuring how they're doing, and frankly, catalyzing more work on that. So we're pleased to work with individual states. We've put out some reference guides around how to measure primary care spend, and we work particularly in partnership with the Primary Care Collaborative in their efforts to work with states to support the states that are already on this path, like Colorado, you're going to hear from Kate, as well as states that are interested in getting into it or earlier on, like New Jersey. The second area where we work in terms of primary care is around multi-payer primary care transformation. We've historically supported the CMMI projects, such as Comprehensive Primary Care Plus. I see Steve Peskins on the call. We've worked with Steve and the New Jersey Blues a lot on this stuff. And we are now taking that work and applying it to Medicaid in particular, because we think over the long run, the states that are serious about multi-payer primary care transformation have a central role for Medicaid in that. So how can we get Medicaid to elevate the role of primary care within its work, whether it works with MCOs or does it directly? So that's how we see ourselves. We're a small operating foundation. We've got to work in partnership with places like Primary Care Collaborative, state-based organizations such as yourself, the researchers, the professional societies like AAFP to help get this word out.
So what have you found to be the most influential arguments when you've been talking to regulators or health plans such as the Blues when you make the case for investing more in primary care, but not increasing that total cost of care? What are the arguments that really seem to resonate and move the needle in advancing the work?
So I've yet to meet a health plan that didn't want to put more money into primary care. They recognize the value of this. They want to do it. They feel constrained by the market in which they operate, because frankly, primary care doesn't have the power, the negotiating power when they sit across the table that a large health system does. So the next best thing they do is they try to lay out breadcrumbs to say, okay, you improve performance for me and I'll give you more money. And that never works, because that is asking the primary care folks to make the investment for the practice changes and then hope that they get rewarded on the back end by the plans. So the plans are looking for ways that they can move more money in, and actually, in our experience, don't necessarily mind the primary care spend requirements if it can be enforced equally on all of them, because it gives them a rationale when they have to say no to people with more economic power. I also think that, and the health plans can be very helpful here, is while they, in exchange for that increased investment, it's okay to ask primary care to do more, to put in place the processes and structures that will get us towards that definition of high quality primary care: 24-hour access, electronic health records, referrals management, all the things that we used to call patient-centered, or not used to, but historically been associated with the patient-centered medical home. So you need the plans, because they can help develop standards for high quality primary care, but the plans need this public movement to say, no, primary care should be a priority first. And the primary care spend measure is a great way to focus on it, because I guarantee you, when you go out to most folks, those not in healthcare, and you say, how much of your healthcare dollar goes to primary care? They're not saying 5 or 6%. They think 20 or 25% goes. I always used to do this. And then when you tell them 5 or 6, they're shocked. And they say, well, we've got to change that somehow. Well, I definitely want my primary care doc to get more money than that.
All of your answers resonated with me. I actually used to work at Horizon Blue Cross Blue Shield and worked on the CPCI initiative, and 100% agree that the goal really was to spend more on that high quality primary care. But what I noticed is that same commitment level isn't equal across the state in all of the markets. And this isn't just in New Jersey, this is across the country. There is a differentiation between how much plans and other organizations are willing to invest in these models in Medicare versus Medicaid versus commercial. I'm wondering if you could speak to that a little bit and how we can break down some of those silos, because as you mentioned, it really does then have an impact on equity.
Well, I'll tell the personal story. In Rhode Island, we put our primary care spend requirement on the commercial health plans. We didn't have leverage over Medicare. And we said, you're going to do this, and it's not going to increase the premium. And we used our rate review authority to make sure that was the case. We didn't exactly say how they would spend the money, and we didn't say to whom they could spend the money. So the health plans were free to give more money to some primary care practices and less to others if primary care practices weren't willing to step up. This wasn't an entitlement to them. They had leeway as to how they would spend that money and where they would spend it. And what we found was great variation. Blue Cross of Rhode Island went heavily into patient-centered medical homes and structure and process measurements. United wanted to do more pay for performance. And then consistently at the end of the year, I was told it still happens. United would come into the office towards the end of the year and say, oh, it looks like we're not going to hit our spend target. We need to get some more money out the door. And then they would find places to spend it, sometimes on good community benefit stuff like the Health Information Exchange or something like that. So you have to, you want to use the ability of the health plans. You don't want to overprescribe it you want to use their ability to generate some striving among the primary care practices and pick some winners and losers based on some publicly available standards. You shouldn't force the health plans to pay more money for mediocre primary care. They've got the capacity to assess what's good. But you need some, Linda, to your point, I mean, these multi-payer, what we learned from CPC Plus is that the regional health plans are the leaders and the nationals are the trailers. And so you need some sort of a regulatory capacity or purchasing with Medicaid MCOs to get everyone to level the playing field for the health plans. It's not fair to ask the regional blues or the regional nonprofits to shoulder too much of a burden. You have to get everybody there together.
So there's a lot of questions coming in about, this all sounds great, but how do we actually implement this? And I'm hearing you say, if I'm piecing through the nuggets here, it's transparency is really key in terms of public reporting about the spending and the regulatory levers, maybe not getting into the weeds on exactly the model or how you're going to spend it, but making sure that it happens and leveling the playing field in terms of the requirements. Is that fair?
Yeah, I mean, you can, Kate will talk some about this, but I think you have to give more authority over your commercial insurance, your insurers, the rate setting process, the rate review process, maybe a standard around affordability. And somebody, either the legislature or the insurance regulator or Medicaid, has to say primary care is a priority. We're going to move it up. So that's the importance of that public table. And frankly, the work that the Quality Institute's doing is to build the political will for primary care. Because there are lots of other mouths out there that have to be fed. You know this. You're at Horizon. We got to elevate the role of primary care. So it's the state saying primary care is a common good. We're really concerned about it, and it's some ability to work with the commercial insurers in a fair and consistent way.
Great, thank you. I haven't even had to ask or prompt questions because they've been coming in fast and furious. I'm going to share a couple with you. One person is asking if we have any comparisons of New Jersey to Pennsylvania. I don't know if you know off the top of your head. Otherwise, I think that's probably something that we can provide after the fact.
I don't know it off the top of my head. I don't know why we just didn't think as we were getting this ready to include Pennsylvania, but you can get to the same data sources that we have.
Yep.
Mostly, yep. I'll give you Kaiser State Health Facts. That's the place to get it all.
Standard, right. Talk to me a little bit about some non-traditional, licensed professionals that are now coming in to have a bigger role in comprehensive care, especially around social determinants of health. Someone's asking if community health workers are part of the defined care team, and if so, if you're aware of any data on their value add and the service and any examples of how their services are reimbursed in some of these models.
No, and I think these are the questions that come up when you get this table around that's looking at primary care spend. So, I think we have to acknowledge the for better or for worse, we're stuck with insurance claims. So if insurers pay for it, then we know about it. And that creates all sorts of difficulties because then people want their own diagnosis, their own procedure code, their own license status. But this is how we track the dollars. And so I think what I think you would find is that the more dollars that are going to primary care teams on a non-procedure basis, then the greater flexibility those teams have to spend it on whatever constitutes high quality primary care, telehealth, community health workers, whatever will improve access. And so I think we have to accept the fact that our administrative systems are always going to be lagging and they're going to be a pain in the backside, but recognize that the more money we can get out in non-fee-for-service ways to primary care practices, the more flexibility they're going to have to do things like hire the community health workers.
Yep. And thank you. We have someone, going back to your point about it's important to have really all of the payers at the table, or as many payers as possible. Have any states had success working with ERISA self-funded plans, and voluntarily sharing data? Any suggestions you have on that? We have, in relative terms, a high percentage of our market is insured through ERISA plans.
ERISA plans are a real challenge. We've seen that on the both on the primary care spend work and on the multi-payer work. I think you can count on a ripple effect, but it's not direct. So when you use regulatory authority to expand, to kind of put the thumb on primary care, some of it will ripple out into the policies for self-insured. But as you probably saw, because we certainly saw this with the CPC work, the health plans could come forth and commit their fully insured dollars, but they couldn't commit their self-insured dollars. They'd have to go back and ask permission from all the employers, and it drove us crazy. And we don't have a systematic solution to that. We do think that leadership is important. That if health plans, now acting as administrators, prioritize that ask to the employers, then the employers are more likely to say yes. It's hard for administrators to do that because they don't want to appear like they're spending the employer's money. We also think that state-based self-insured are the first place to go. So you got to make sure that state employees are, if they're self-insured, that your big health systems themselves, that they're self-insured, that your universities, that they are, as locally based folks, they should get the first, they should be the first ones you go to of the ERISA plans, as opposed to the branch office for a national plan, which can be really hard.
Yep. I think our largest employers in the state are a lot of our hospital systems, actually.
Right.
So they're
Right.
very familiar with healthcare spending.
Yeah.
Well, I want to thank you again for all of the wisdom you've imparted us with. I think it's been really helpful. I don't know, still several thoughts around public health. I wonder if you could just, maybe to wrap up, share some thoughts on how, if we had had a stronger primary care system and greater connectivity for everyone, really primary care is a common good, what that would have meant in the past 2 years over the pandemic. And then now looking forward, how does building up a strong primary care system connect to really reframing and rethinking about public health?
I guess I would ask us all to imagine how we could have approached the pandemic if two things: everyone had a usual source of care that they felt quite loyal to and quite attached to because they built up a trusting relationship with them. And then those usual sources of care had a systematic way of talking to our public health authorities. Think of every challenge that we faced during the pandemic, the initial messages about the scope of it, concerns about testing, the public health messages about how to stay safe, and then the questions about vaccine. And if we had those two things, if everyone had a trusted usual source of care that they had really easy access to, and if all those usual sources of care were systematically communicating with public health officials, you would have much more effective messaging and much more effectiveness. I mean, imagine if we could communicate with our primary care teams the way we communicated with schools. We were much more effective about, and have been, continue to be much more effective about messaging around schools. It didn't take away all the controversies, but it made it much, we had a much more of a system than what we have with in primary care. And that's why I keep lifting up the example in Maryland, because Maryland had been working on this for ages, not ages, they've been working on this for years to build up capacity in primary care, to build up care coordination teams, to build up messaging capacity. So when the pandemic hit, the Department of Health, and they had health information. They had a claim system. They had shared electronic health records, so they could move information back and forth. And so that results in a 20% lower mortality rate for these primary care practices. That's enormous. Imagine if we had, even before vaccines, put vaccines aside, we had 20% fewer deaths because we had a strong primary care infrastructure. That's what we're denying ourselves because of the fragmented way we do this work. And I think the only way that's going to change is this kind of collective work that the Quality Institute in New Jersey is trying to inspire. So thanks for what you're trying to do.
Thank you. I think we pay for it on the front end or the back end. And I think really what we're trying to argue is to pay for it on the front end for quality and comprehensive care and relationships. I definitely urge everyone to take a look at the state comptroller's transparency dashboard, which is showing how much the state spent on the COVID response and all the separate contracts. And it's literally hundreds of millions of dollars on public health efforts to communicate with people about vaccination and to contact trace and to do a lot of the things that if there was a stronger connectivity and a stronger primary care system out there, a lot of that work would have been done as part of a stronger healthcare system. So think about if all of those dollars had gone into primary care and what we could have on an ongoing basis. So we have the resources. I think it's just applying them properly. So looking forward to working with you on this.
Thanks, Linda. And I just realized there's a comment in here from Howard Haft, who's led the effort in Maryland. So I'm here yakking off about Maryland, but you got a lot smarter people than me in terms of how they actually did that work. So I encourage you to follow up with him as well. And thanks for the chance to speak with you all. Good luck with your work.
Yeah, thank you. Thank you again, Chris, and appreciate your time and your presentation. Next, we are going to move on to our first panel, and we're going to be discussing how states are reporting on primary care investment and achieving those benchmark goals. And with us today, we are lucky enough to have two individuals, and I think they're popping up here. Let me just work with my technology. Excellent. I'm pleased to welcome Larry McNeely. Larry is the Director of Policy with the Primary Care Collaborative. As the PCC's Director of Policy, Larry helps shape and advance a policy agenda aimed at building a comprehensive, team-based, patient-centered primary care system. So thank you, Larry, for being here. He coordinates PCC's Policy and Advocacy Committee and Behavioral Health Integration Committee, also a topic near and dear to the Quality Institute. Mr. McNeely earned a Master's of Public Administration from West Virginia University, and he also holds a Bachelor of Arts from St. John's College in Annapolis, Maryland. And we're also pleased to have with us today Kate Harris, who is the Chief Deputy Commissioner of Life and Health Policy at the Colorado Division of Insurance. Welcome, Kate. Kate has spent her career working at the intersection of public health and public policy, primarily on the implementation of the Affordable Care Act. She worked in Washington State and now in Colorado, where she joined the division in 2019, and she oversees much of the division's work, increasing consumer protection and Coloradans' access to affordable, high-quality coverage and care. And Kate holds a Master's in Public Administration and a certificate in Public Health from the University of Washington. So welcome to both of you. Appreciate your time and your interest in this topic and willingness to share all the work you've been doing with our colleagues here in New Jersey. And actually, we have a lot of interest across the country that's participating on today's call. So you're really expanding your sharing of knowledge, not just in New Jersey. So thank you for that. And I know, Larry, you were putting a whole bunch of different links in the chat. Too many for me to keep track of, but I appreciate it. And we can send those out to all the participants after the conference today. So thank you. And why don't we start with you, Larry? I'm wondering if you can share a little bit about some of the states that are prioritizing comprehensive primary care, and whether they're doing this work through legislations or regulations. Just tell us about what's happening out there with the concept of benchmarking and then ultimately increasing the levels of investment in primary care.
It is an exciting story to tell. The momentum in states that you all have contributed to here in New Jersey with this budget language last year, and the work of the public servants that are on the call today. But I should just say a bit about who we are in case folks on the call don't know. We're a nonprofit, nonpartisan membership organization, the Primary Care Collaborative. Some 63 national stakeholders are executive members of the organization, and we produce evidence and convene stakeholders and advocate for a stronger primary care system. And I'll just say that it's been, over the past few years, we forged this partnership with Milbank, with a number of state advocates, and we've been convening a state primary care investment work group on a quarterly basis to share information across advocates, state officials, and the national stakeholders that sit at our table. And I coordinate that work group as well. And so we've been witness to and hopefully played a part in spreading this approach that began with work in Rhode Island and Oregon that is accelerating across the country. 11 states, by my count, and maybe I'm missing one, but I don't think so, have published reports on primary care spend in their state, either individually or as part of a region like the New England states have. That's 6 New England states: Colorado, Delaware, Maine, well, they're part of New England, Oregon, Washington State, Utah. I also want to share that just this legislative session, Maryland, California, Connecticut, New York, Nebraska, each have pending legislation to set targets across payers and to either to authorize measurement or to set targets across payers for increasing primary care spend with the input from the multi-stakeholder process. Maine, Massachusetts, Washington, Vermont, all are folks who have measured, but want to build on that existing reporting and set a process to set spending targets. It's worth mentioning that Utah has now advanced through both houses and is sending a bill to their governor to have yearly reports across payers in that state. So forgive me for droning on, but there's a lot of good news to report here, and a lot of partners for folks here in New Jersey as you're trying to make this work.
That's great. And definitely we will be tapping into you for examples of all of that language and all of that work. Thank you for sharing that. And I think let's dive back to you, Kate. And since you are actively doing this work in Colorado, maybe you can share with us sort of the story of how Colorado started on this journey, and now the targets that you've set, and what implementation steps you have in store in Colorado.
Sounds great. And thank you so much, Linda, and everyone for having me. This is really fun to hear the conversation, and I'm happy to provide a bit of the perspective from Colorado. So we are about 3 years in. Our primary care investment bill passed in 2019. And so it helped stand up a collaborative specific to Colorado, where we have a combination of payers and providers. We also have our Medicaid agency represented, as well as Center for Medicaid and Medicare Services on there, really so that we have the voices of multiple payers looking to align the recommendations of the collaborative across the markets. So they have published 3 annual reports so far. And a lot of work has been done, both with the recommendations that went into those, and then also the data that's informing those reports. So first thing they did was they defined primary care. One of the things we saw, and we've really followed in the footsteps of a lot of other states, Rhode Island, Oregon, that had been doing this for longer than us, but we looked at the definitions of primary care in multiple states, and then what was also being used in Colorado. And the collaborative came up with a definition that they felt like really reflected, their needs and values. There was a lot of discussion around, do you include OB? Do you include behavioral health? How do you kind of center equity into the definition that you are working with? And so they defined primary care. We then took that definition to our all-payer claims database to build the baseline for measuring the primary care spend in Colorado. 2021 was our baseline year. And, in hearing Chris's comments earlier, we fit right into that. We're right at about 5%, on average. Our commercial carriers vary within that, but the total spend is right around 5%, and it's lower than the national average from what we've seen and have been able to compare across the definitions. And I think that took people by surprise, honestly. And so what that helped us do was the collaborative decided to, for the first 2 years, so for 2022 and 2023, they recommended a 1% increase by carrier. So if a carrier was at 6%, they want them to go to 7. If they're 7, move to 8. Obviously, for the ones who are lower on that spectrum, it's going to be a little bit more of a lift for them to increase their spend in primary care. But felt like that was a really important initial step. And so we'll be looking at, how that's working in 2022 and 2023. And then they will look at either continuing that recommendation or adjusting it somehow. The next thing they did was they, really looked at how those additional funding dollars should be spent. And, I think really trying to strike that balance of enough flexibility for carriers to be able to be innovative and to, work with the providers on what's working well. At the same time, really putting some pressure on increasing that spend in ways that drive quality, that drive equity, that are in towards prospective funding. I think we saw with the COVID pandemic, the impact on primary care providers was really significant. And, had more of that prospective funding been in place, I think, we would have been in a different and better, stronger place from a public health perspective, quite honestly. So that was a lot of their discussion, particularly over the last year and a half or so, is the prospective funding piece, to these payment models and how can they, how can payers and providers work together to really to make progress there. So that's a high level, what we've done in Colorado so far. I would say that, it's going really well. We have a really engaged group of collaborative members here, and are just, really grateful to Chris and Larry and the other states that have gone before us, because, we rely so much on that research and body of work that's been built as we implement here in Colorado.
That's great. Thank you for sharing us the step-by-step on that. And I'm wondering for either you or Larry, really both of you, maybe you could talk a little bit about that flexibility that Chris mentioned in terms of, how each plan, or maybe each plan within each market, is increasing their spending, and I guess some of the maybe pros and cons of that flexibility, because I can imagine it's great in certain ways, but then it also maybe complicates things in terms of both measurement and regulating. So I'd love to hear if New Jersey's muddling this over, what should we be worried about in that respect? You want to start, Larry, and then we'll.
Yeah, I'll go ahead and start. And I love by the way, a chat, how have you included the voice of primary clinicians in Colorado? I'm eager to hear. And I think that's vital, as it is to get all stakeholder voices at the table on this. I'll say that from the perspective of a multi-stakeholder coalition that plays a great deal at the national level, as well as trying to support the work that's going on in states on this, that looking at the primary care delivery system across the country, but also in any one state, there is no homogeneous way of delivering primary care, right? And if you're starting with uh, diverse practices, working in diverse ways in diverse communities, you know, as an organization that knows fee-for-service payment is something that systematically disadvantages primary care investment and really access to care and equity, and knows that we want to move away from that. The reality is you got to start where people are at, and that you want to hold in your mind the reality that a one-size-fits-all transition and timeline just wouldn't work based on various practices, various payer practice relationships, various communities. And so you've got to find a way to move everyone in a single direction, adaptive to that diversity. That's just my 2 cents. But it's also, and I love Peter's comment here, it's not enough to simply start where people are at and take baby steps either. So I think the proof is going to be in the pudding, all having those conversations here in New Jersey.
Yeah.
Yeah, so I would just add, you know, I think from our perspective here in Colorado, we've used the LAN framework, and, you know, really,
Do you want to the learning? Do you want to tell everybody about what that is? Just in
sure.
case
So really just a spectrum of alternative payment models, and, you know, a spectrum of quality and risk sharing that goes from, you know, kind of very basic quality components to more advanced, you know, risk sharing with payers and providers. I think, you know, what we've seen is that there are some, you know, to Larry's point of meeting people where they're at, there are some providers who are already operating sort of further down the spectrum in, you know, risk sharing, and, you know, who are ready for, you know, really more advancement in their APMs and how those are functioning. And then there are some who are just starting out. And, you know, and I think what we've said is we're not trying to move, you know, if we're thinking about this as a spectrum, we're not trying to move a provider or a payer necessarily from one end to the other. We're trying to get them just further along, right? From, you know, can they take steps? If they're, you know, functioning in a LAN 2 right now, can we get them to a 3? If they're in a 3, can we get them, you know, closer to a 4, et cetera. You know, so I think leaving room there that we're using a shared framework, but also that balance of meeting payers and providers where they're at, and acknowledging that this is not going to be an overnight change by any means. I think the other thing I would say is, you know, being able to, as you're doing this, measure particularly the non-claims-based spend is going to be really important, and having enough flexibility in that, you know, I think in many ways hasn't really been done before, you know, for payers who are including, say, loan repayment for primary care physicians as part of their, you know, increased spend. How do you reflect that and measure that? And so those questions, and leaving room, you know, both in your structure, but also in your measurement for flexibility, I think is huge.
Great, thank you. One of the comments mentioned, and so I want to circle back to this. Let's say the state is an active participant, like in Colorado, and health insurers see the value and they're an active participant. But how can you get those health systems, who are also some of the largest employers, engaged? I'm wondering if in your collaborative conversations, Kate, let's just take your round table, how have you really been able to bring some of those larger health systems into the conversation, particularly if they're thinking of it as a zero sum gain or loss, as the case may be?
Yeah, I would say we've been really fortunate. I think, you know, we have some great representation from providers, including from providers that are part of bigger systems here in Colorado on our collaborative. I think about a quarter to a third of our collaborative members are clinicians. And so, you know, and they're everyone from small rural providers, you know, who certainly bring a perspective, to, you know, hospital owned, you know, primary care offices, to pediatricians, right? That there's you know, really unique challenges there. And so I think having, not only having good representation and you know, from clinicians, but different types, has been really key for us because, as we work through, some of the more technical pieces of implementation, it really functions different for all of them. And so making sure that all of those voices are well represented has been really critical.
I'll just, I'll say two things. One, the finances are changing for your larger health systems as well, with increasing responsibility for population health. And to that extent, there's going to be some leaders in those communities who are making the bets they need to on primary care, while I think it's critical independent practice remains an option where it is. I do want to circle back just to say, to Kate's point about non-claims payment, you don't have to reinvent the wheel entirely in that, as much as you might have flexibility to tailor things to your state, your needs. But Balick Consultant and Milbank have got a great report that came out in 2021 with a proposed approach. It's getting a look at around the country by various states that are doing this work, and adopted by those 6 Northeast states that put together a regional support. So I think we have an opportunity to move forward on that too. So there are things you'll need to navigate with everybody at that table, but it's a doable piece. And if I'm not wrong, Rhode Island and Oregon, they do have some large health systems, some of those cities there. So
well, thank you for raising about the Milbank and Ballot report. New Jersey is lucky enough to be working with them on our benchmarking project. So we will be sure to put together a lot of these resources and send them out to all the attendees today. We are, again, like the last panel, this is generating a lot of enthusiasm and with questions and comments. So I'm excited about that. And I want to ask you guys a couple of them now. So Kate, we have a question about what's happening inside those conversations at the National Association of Insurance Commissioners. Are they on board with this work and this investment, and is excited about making it a priority as you are in Colorado? Or can you share some of those conversations with us?
I will say that particularly as more and more states, look towards passing, similar laws around investing in primary care, I think we do get more questions from other commissioners and at, the NAIC level around, how the past few years have been going for Colorado. And, I think we're happy to share our experience, obviously, but I do think, particularly with COVID and kind of, recognizing some of the needs for increased investment in infrastructure and primary care, I do think that there is a new level of interest, I would say, in states that are going this direction.
Great, that's good to hear that. I'm curious, does it bleed into looking at just their responsibility to look at network adequacy, or does that come up in these discussions? I mean, as you're supporting, as we are supporting and investing in primary care, the hope is that we're also reinforcing and increasing network adequacy in a really broad way across each region. Just curious if there's any connectivity in those conversations around network adequacy.
I think there definitely is. And I think as we, as regulators get more advanced in network adequacy and drilling down to different types of providers, for example, we're doing some work here in Colorado right now around culturally competent providers as part of our Colorado option, and really building new tools around how we assess network adequacy. I think that on the primary care side is certainly a piece of that. Really also looking at the integration between behavioral health and primary care. And then I think the last thing I would say is the movement towards telehealth, I think has been and will be really important. Another thing that COVID taught us is that, there's a lot of primary care that can be delivered that way really efficiently. Some certainly can't. but that there are benefits there.
Great. Larry, I wanted to move on to another hot topic, but if you want to add anything
Yeah.
on, yeah, go.
No, I was seeing one of those Q&As. I want to get at that.
Oh, okay. Well,
that
let's
equity
talk
issue.
about some of the consolidation that's happening and some of the practices being either merging with hospital systems or being bought up by or invested in by private equity. I'm curious, how does investing in more in primary care and supporting independent primary care connect with some of those trends? If you guys could comment on that.
I mean, I can say as an organization that, again, recognizes folks are starting for a lot of different places. I think we need to have primary care ecosystem that works with multiple different types, whether you're part of a larger system, whether you're independent practice. The question is whether independent practice is going to continue to be viable. And the one thing that I'll say is that if you have payers in a community, particularly payers like Medicaid or the state employees plan, but across payers who are investing in primary care, it changes the calculus for a practice like mine, a one or two. I have a single physician with a single PA. That's my primary care practice here in Maryland. It changes the dynamic, the choices that they have to make to be able to adapt to a circumstance where folks are dealing with the need to transform, to adopt EHR systems, to be ready for value-based care. If you're getting more resources in the door, you can make those transformations at the practice level to a greater degree. So.
Great point. We have a really important question that I want to make sure I get to for both of you. Are there promising examples of how states are trying to address the equity gaps in access to primary care across different racial ethnic groups, as mentioned earlier in the presentation? And Kate, I think you were starting to go there with the discussion of network adequacy, but curious if you would share, both of you would share just specifically as this is being discussed in your state roundtables, the role of equity in addressing healthcare disparities and inequities, and how primary care increases addressing equity.
I'm happy to. Yeah, it's been a really significant conversation amongst our primary care collaborative, particularly the past couple of years. They have woven equity recommendations into their last 2 annual reports, which are on our website for folks who are interested. Those are posted publicly. I think it has become more of a focus. I think part of the challenge is the data collection side on, both the payer and providers, how that demographic data are being collected, and, so that they can really understand better the population that they're serving, but also the population of providers. We know that there are better outcomes, from a primary care perspective when a provider and a patient are of, the same race, right? We know that there are, really outcome differences there. And so being able to, push providers to expand, their own practices and who they are well equipped to treat, whether that's, on the race ethnicity side or specific training for, how to best serve LGBTQ patients, right? There's a lot of work, I think, that still is to be done there. And then also, how can, from the patient side, how can patients know, if they are looking for a specific, provider that, is equipped to treat a transgender patient, for example, like, how are we reflecting that in provider directories, and really ensuring that folks can get the care from people who, who look like them, who have their lived experience. We have a lot of work to do there, but I think, that's those opportunities are coming more and more and are definitely a large focus here in Colorado.
Great, thank you. And easier to address or hopefully healthier system to address it if we're investing more in primary care. Larry, I know you want to say something, so please go for it.
Yeah, gosh. One, the equity challenges, the health equity challenges, primary care has a vital and critical role to play. It is not the only solution. So what role could it play? I mean, it could play it rather than having patients, including patients with barriers, be it barriers with a clinician who's not hearing them. It's barriers that might be language, barriers of trust, right? For very good reason. The question is whether that patient is being shuffled through for a 5-minute visit, right? For a strapped kind of a very limited healthcare team, right? Or whether investments have been made over time, whether in New Jersey you're able to do what Rhode Island has done, which has doubled in primary care spend over a decade, right? They moved from 5.8% to 12.5 as of 2019. In that circumstance, you can have a community health worker who can do the outreach. You can have primary care be more rewarding. So if you've got someone who has a high-level clinician or physician who has gone through the schooling, that primary care is attractive, right, for them professionally. You can hire the behavioral health team to address whole person care. That's the choices that'll be in front of you if you can make this process work here in New Jersey. If you don't, continued consolidation, whether it's in health system or not, they're just moving folks through the door, getting as many visits as you can. That's not a recipe for equity, to my mind. I do want to call out Maryland, who has made complementary investments in health equity resource communities, an incredible piece as they've been trying to do primary care transformation. So that public health partnership is there. So.
Great. No, thank you. Thank you both for all of that. I don't know if there's, I feel like we did a whirlwind of answering all the questions, and we really covered both how states can do this, the importance of having that multi-stakeholder input, the importance of having the regulators, the payers, the professionals, as well as the patients and caregivers around the table, really providing the vision for this. So thank you all for this great advice that you've imparted it to us. Last thoughts that are top of mind for anyone before we turn it over to Mary in the next panel. Anyone? All right.
Well, we'll welcome some New Jersey folks on
Mm-hmm.
our call over the next few quarters. PCC.
Great.
Yeah,
Great.
This is an exciting conversation. We're happy to support, the efforts going forward. So please don't hesitate to reach out.
Well, thank you. Thank you guys both for your partnership and for being with us here today. And at this point, I want Hello. Okay. I'm sorry for that technical glitch there. Hopefully we didn't lose anyone. At this point, I want to introduce you to the panelist for or the moderator for our next panelist, Dr. Mary Campanola. Mary is playing many roles today, and we are very lucky to have her. Not only is she on the Quality Institute's board of directors, but Mary is she's a family physician and a geriatrician. She's the medical director for value-based programs and payer contracts with Virtua Medical Group. She's a director for the board with the American Academy of Family Physicians and their foundation as well. And she's a past president of the New Jersey Academy of Family Physicians. So you are in good hands, panelists, and it's great to see you, Sean and Steve. And I'm going to turn it over to Mary. Thank you so much for being here today. Thank you.
Thank you, Linda, for this opportunity. And this has been a fascinating conversation so far, and I appreciate everybody hanging in with us as we talk about our own state of New Jersey. So we're very fortunate to have two panelists that I'm going to have a conversation with. First is Sean Kavanagh, who's the Chief Policy Officer and the Chief Commercial Officer from Aledade. Sean previously served as Deputy Administrator and Director of the Center for Medicare at Centers for Medicare and Medicaid Services. He was responsible for overseeing the regulation and payment of Medicare fee-for-service providers, privately administered Medicare plans, and the Medicare prescription drug programs. That's a huge panel of things to oversee, I think. Previously, Sean was the Deputy Director for Programs and Policy in the Center for Medicare and Medicaid Innovation, where he was responsible for overseeing the development and testing of new payment and service delivery models, including ACOs and medical homes. He attended University of Pennsylvania and the Johns Hopkins School of Hygiene and Public Health. So welcome, Sean. Our next panelist is Dr. Stephen Peskin, MD, Senior Medical Director of Horizon Blue Cross Blue Shield of New Jersey. And Dr. Peskin is the Senior Medical Director, Pilot Lead at Horizon Healthcare Innovations, which is a Horizon Blue Cross Blue Shield of New Jersey company. His expertise encompasses physician leadership, medical delivery management, performance improvement in healthcare, contracting, applications in technology and mobile social media, clinical and scientific communications for healthcare professionals and consumer audiences. In addition to all that, Dr. Peskin continues to work at the Robert Wood Johnson School of Medicine at the University of Medicine and Dentistry of New Jersey. He serves there as a clinical preceptor and instructor at the Eric B. Chandler Clinic. He's course director also for the Internal Medicine Grand Rounds at the University Medical Center in Princeton, and is currently the Associate Clinical Professor of Medicine at University of Medicine and Dentistry of New Jersey, Robert Wood Johnson Medical School. So again, we have two illustrious panelists here. I appreciate working with you today. And certainly have worked with Dr. Peskin over many years in some of our ventures in value-based world in New Jersey. So first, I'd start off maybe with Sean first. Wanted to ask you, Aledade's a national company, has many endeavors in various states. So wanted to ask you, what lessons have you learned that apply to investing in primary care that could be implemented in New Jersey?
Yeah, thanks for the question. And for the listeners who don't know what Aledade is, we're a company that works with independent primary care doctors, and we partner with them. We don't purchase the practices. We don't own the practices. We become their partners, and we help them enter value-based contracts and then help them be successful in them. So we work in 37 states. So we've seen a lot of the different environments, many of the states that Chris and Larry and Kate were referring to in the previous discussions. I guess I would summarize the lessons in just a few points. One is leadership absolutely matters. Whether it's an organization like the Institute here in New Jersey, or a governor, a secretary of health, it takes a group of people really driving the primary care agenda to get change. Really, what we haven't seen enough of, but I think we're beginning to see, is we'd love to see the employer community taking the lead, because that's really those who are most invested in it. But the bully pulpit, someone taking leadership and driving this agenda, is absolutely essential. It just won't happen. As dire as these problems are, it won't happen on its own. The second lesson is it's hard work. Our goal is not to have a report on how much money is spent on primary care. Our goal is not to have a target. The goal is better care and lower cost. And all those things might be essential in the pathway to get there, but it's going to be hard work. The example I would give is, in several states that we work, the state has an explicit goal of spending, a certain percentage of premium on primary care. But if that's all the state does, we work with one Blue Cross plan who says, I'm not paying health systems a lot of money because I want to, it's because I don't have any choice. And so if I have to increase my percentage spend in primary care, it gets inflationary. So I got to, if the health system gets a 8% increase, that means primary care has got to get a 15% increase. And it's not getting us towards the goal. And you see some states addressing that. Chris mentioned in Rhode Island, they have actual premium review and potential controls. In Maryland, which was referenced, they can actually control the rates of increase that hospitals are getting. But the point being, it's hard work. And the last thing I would say is there's really two very different worlds of primary care, which are, and we focus on the one of them, which is independent primary care. And they are in a very different situation than the primary care practices that are owned by health systems. They don't have the capital. They're currently getting the worst fee schedule in the market, typically, because of the lack of leverage. So the starting point of trying to get them to transform is very different than the health systems. So I'll pause there.
Thank you, Sean. So we'll next address the next question to Dr. Peskin. I think we were talking earlier about how some of the regional insurers sometimes have been stronger movers in this arena for supporting primary care than the national companies. And I would have to say Horizon is an example of that. Can you give us a little bit of information about what Horizon has done in the alternative payment model world and any future plans you have for that?
Yeah, so thanks, Mary. And Mary's been a vigorous leader, and I see Peter Carazone and Lisa Locke-Ruba and some others on the phone today who've been intimately and instrumentally involved. So we started on this journey with the New Jersey Academy of Family Physicians, as Mary well remembers, about 13 years ago. And really, we're going to look to go from trying to just strong arm physicians and healthcare organizations, probably especially physicians, on rates, because we had the dominant market share. So we could do that, to really thinking kind of in the words of one of my personal heroes, Don Boerwick, radical redesign. So what does that mean? The radical redesign was about changing the payment model, changing the way we work with clinicians, in particular primary care physicians, data exchange with clinicians, data science, analytics, and working on new kinds of efforts. Like I see my colleague Valerie Haar on here, so working in our program called Neighbors in Health, which addresses some of the social drivers, social determinants of health, and then working in concert with you, Mary, or with Peter, with others. So the big effort was to, and Sean referenced this, change the way, and Chris as well, change the way we pay physicians, looking at paying for clinical outcomes, patient experience, managing overall cost, which is not always something that primary care physicians say is in her purview, but managing overall cost. And then a fourth part of it, which we feel responsible for, and I know the physician leaders and non-physician leaders on the phone that are running healthcare organizations, like Sean with Aledade, is healthcare professional sustainability. As Christine Sinsky says it, bringing back joy into the practice of medicine, or nursing, or medical assistants, or other healthcare professionals. So that's how we've been approaching things. There've certainly been bumps in the road. It's been far from perfect. Linda Schwimmer was there before me at the very, very beginning of this endeavor called Horizon Healthcare Innovations. It's now folded back into, and is the kind of core way we work with our clinical partners, whether she be a small family practice office or a large health system, and kind of everything in between. We also focus on subspecialty care with bundles and episodes of care. Again, our focus today is around high value primary care, which is certainly is at the core. So again, it's kind of thinking about that quadruple aim, thinking about paying for outcomes, for patient experience, for the ability to manage the total medical expense or total cost of care. We bring tools and insights. We've done a lot over the last 5 years in behavioral health, working arm in arm with our primary care physicians. Virtual care has been massive in the pandemic across the board, and probably most especially in behavioral health. Again, I mentioned our Neighbors in Health program, which again is there to support, undergird, providing community health workers. And some of the practices, Virtual may have those as well, and so forth. But again, our role at Horizon is to really support, undergird, and not undermine, which is probably a lot of what physicians have historically thought about insurance companies is not undergirding, but undermining their relationships with their patients. So those are some of the key fundamentals. We've had some good success over the years. Again, we've had our share of challenges as well. The data part of it is always difficult with a myriad of electronic health records and interoperability and those kinds of challenges. But we're getting there. We're getting there.
Thanks, Stephen. Just back to Sean again, I think you said a couple of important things regarding how this kind of work is very hard work. It does take time. And, you know, again, as we've discussed, I'm part of a large organization, and we've had the good fortune to work with some of the payers to develop our clinically integrated network, to develop our practice support team so that we have community-based health managers that are social workers. We have population health nurses assigned for each practices. We have behavioral health that certainly needs to grow further, but we do have some licensed clinical social workers assigned to the practices. We have the data management assistants. Again, big challenges, as Steve was just saying, but we have that. And Sean, your company works more with some of the smaller practices that have not been fortunate in those regards to have that kind of support and ability to try experiments that may not bring immediate return on investment, et cetera. So just curious about any other wisdom you have for the group as to how we can help support the smaller independent practices.
Yeah, I think that's an important issue here. And just to be clear, Aledade works with practices of all size. We work with some quite large practices, but also, as you said, we work with practices that are, you know, one physician, maybe a physician and an NP, and everything in between. And again, it's really important to think of what is the position of these practices before they get into value. Like I said, they've got the worst fee-for-service contract out there, but they want to do better. Like all the goals that Dr. Peskin just mentioned, they share those goals. They're fully aligned with Horizon, and we're very fortunate to work with Horizon. But they need help. Like if they're going to get into value-based contract, they need to be able to look at take in data, analyze data. And for smaller practices, that's often hard. So they can do what many practices in New Jersey did, which is get a partner like Aledade. But often they'll need, you know, some upfront money, and there are, you know, many of the ACO type programs do provide some upfront money. And I think that's particularly important for the small to medium-sized practices. The other caution I would have is, you know, the payers understandably like value-based deals that have two sides of risk, so that the practices or whoever's taking the deal has real skin in the game. I know when I was in Medicare, you know, I liked that as well as the payer. But it was important to keep in mind, like the ability to take risk varies tremendously. A large health system in New Jersey or anywhere, you know, taking risk and not doing well, none of them want to not do well, but, you know, it's not going to change the viability of the health system. But if a group of practices come together and take risk on total cost of care, unless it's properly calibrated with the payer, it can be, you know, threatening to the practice. So I think the lesson here is these value-based contracts, practices that are small and medium-sized, this can be a very viable path, not just to sustainability, but to really change the level of investment in primary care. So that the payer gets lower costs, the practice gets more, you know, the increase in financial investment we want. The patients get better care, which is really what we all want. But to get there, it takes a lot of learnings on both sides. The practices need to learn how to deliver care better and at lower cost, and the payers need to learn, like, how do you work with this unique set of providers that don't have the resources of a big health system?
Thanks again,
We
Sean.
just made a comment in the chat, and to what Sean Kavanaugh said about learning how to deliver care better. So there's a lot to unpack there. And it just would say that, again, as I said in the chat, culture eats technology for lunch. So I was in clinic yesterday working with a resident with a woman, 58, morbidly overweight, refractory hypertension. We talked about hyperaldosteronism. I won't get into a lot of clinical minutia, but diabetes almost goes without saying, chronic kidney disease. So the ability to relate to her and to be able to meet her where she's at and to have a care team, the medical assistants. We did call in a community health worker to do a curbside consult while she was in the office. So those things to me are just are fundamental. Kind of goes back to Peter Anderson's book, The Familiar Physician, where he gives accolades to Paul Grundy, who was one of the founders of the medical home.
If I can tell an anecdote that I think fully supports what you're saying, Dr. Peskin, because I think you really touched on something important here. When I say data and analytics, it all sounds very complicated, but it really at times is incredibly simple. When I was in my previous job at Medicare, there were some studies published that showed if a patient, when they were discharged from the hospital, saw their primary care doctor within a week, they had much lower rates of readmission, simply seeing the PCP upon discharge. So in Medicare, we created a billing code. Like we solved all problems at Medicare with a billing code. So we created the transitional care code and we said, doctors, we're going to pay you to see the patient. And we thought, great, now we'll get better outcomes, lower readmissions. And what we got was nothing. Like no one used the code. So I called up a bunch of doctors, the family physicians and others, and why aren't you using the code? They're like, we don't know when our patient's been discharged from the hospital. Like, we'd love to do that. And so, it's not rocket science or like advanced technology and analytics to simply have a ping to go to a physician practice to say, your patient was discharged yesterday, reach out to them. But, in a practice, just, barely trying to keep his head above water today and trying to, move people through the 7 or 8 minute meetings, there's no one who's dedicated. There's no one setting up that data alert, or setting up, but this is where Horizon, Aledade, state can come together and like, how do we provide this very basic piece of information to the practices and then teach them how to act on it? So Dr. Peskin is exactly right. It's the culture, fairly basic things supported by technology that doesn't need to be that advanced.
That's excellent points there, Sean. Thank you for that. And thank you, Steve, too. I just see a comment in the chat. I just thought it's probably worth reflecting on it a little bit is about the concept of taking on risk. And I guess that goes into one of the other questions I was going to ask you all is, why aren't these primary care alternative payment models being adopted faster, given that they do have some benefits for either, the practices that are structured in the right way to handle them. But, as we're seeing now with Primary Care First, which is the CMS program that has been inherited from CPC Plus, there is some downside risk in that, meaning that depending on your performance, practices might be able to lose some money up to 10% on their Medicare payments. So that would be my broad stroke trying to define that. But I was just curious about like your take on some of that and any other reasons why you think this hasn't been adopted in a wider fashion.
I'll go first. I'm sure Dr. Peskin might have something to say about it too. Yes, I think you did a good description, which is some of these new models, practices or health systems can earn a bonus for achieving certain goals, whether it's quality or reducing costs. And taking risk in this context means once a budget's set, if they overspend that budget, do they owe money back to the payer? These take all sorts of forms. Sometimes, for example, the payer will provide the practice like a care management fee up front, so several dollars per member per month to help them invest in care coordination, and that amount is the amount that's at risk. So, but sometimes it's a percentage of the budget, which can get quite substantial. I know in New Jersey, you have regulations, your ODS regulations that require certain, have certain requirements before providers take on risk. But we do have these models around the country. Medicare has both models, one-sided and two-sided. It's taken as a matter of faith among a lot of people that the two-sided models are very powerful, and that's where we should get to. And an earlier panelist referred to the Learning and Action Network framework, the LAN, and in that framework, two-sided risk is considered an advanced model. I have seen, though, in the data when I was at Medicare, physicians that took risk but stayed in one-sided actually did very well. So it's not I don't know if it's necessary. At Aledade, we like to move to two-sided risk because we think there's a bigger opportunity there. I don't know. Dr. Peskin, do you want to add anything to that?
Yeah, I mean, our as Sean knows, that is an effort underway is to have reasonable, Mary, risk sharing. Certainly, we had some travails in New Jersey maybe 25 years ago with a major bankruptcy, and that put in some guardrails by the state of New Jersey around clinical organizations taking risk and then having to have some stress test, to use the SEC term, to ensure that an entity was creditworthy to assume a certain type of risk. So we are sanguine about the shared risk, but we also, recognize that, again, we don't want to put significant risk on, say, a 7-person family physician practice that could literally be wiped out based on a few bad cases or something like that. So that is an effort underway. Again, we're also doing this with subspecialists in cancer care and some other areas. So that is part of our effort underway. To Dr. Karazone's point about risk coding, which is another word where risk is used, Peter, in violent agreement with you, some of the administrivia, as one of my former bosses used that term, some of the administrivia is getting in the way of conversations, which I think are absolutely vital. I'm not the most up to date anymore. The residents I work with can run circles around me with renal tubular acidosis type 1 and type 2, but I always admonish them to get to know people and understand. Oh, you live in Ewing. Oh, you live in Highland Park. Oh, do you have children? What's your situation at home? Are you working? How are you feeling about your relationship with your children? Those things can be sometimes more important than getting the blood pressure down from 138 to 132.
Well said, both of you. Yeah, I think the one of the things that just insert my own opinion, I think, was it's partly these programs haven't caught on also because of this, they're not simple enough. We need simplicity and consistency, as I think you've been kind of describing. And things like HCC coding, unfortunately, is kind of something nobody's ever learned in medical school. And we have like a cottage industry now to try to teach us that and to meet the measures so that we might be able to gain more in say the way the primary care first is structured. So there's good and bad in that, but that's kind of the program right now in any case. I think I saw a question that's come up twice here, and I think goes a little bit to some of the other things we can do for practices to help improve the in the practice care for patients, as well as hopefully reducing cost of care. We've heard that Aledade had a recent investment in an advanced care planning company. And just wondering if you could explain a little bit, Sean, how that might work. And also, again, Steve, if you have anything in Horizon's realm that would also reflect on the same end-of-life planning care.
Yeah, thank you for that question, because that is a recent development at Aledade. So prior to the recent acquisition, what we've been doing is providing data and coaching to primary care practices to change their workflows to make sure they see the right patients at the right time and focus on what really matters to the patient. But we've been looking at a series of investments around how do we further support those practices. And especially when the senior population there is involved, which many of our practices are, family practitioners, so they deal with seniors. End of life care, advanced care planning, it becomes really important. But again, that can be time consuming for a practice. It may be a skill, those kind of very difficult conversations may be a skill that they weren't trained in when they were in medical school. So what we did was we went around the country and we looked at a bunch of companies that were starting to do interesting work in this area. And we found one that we partnered with. They're called Iris Healthcare. And then we ran a randomized controlled trial. So we literally used data to test whether their intervention worked. And what we found was our doctors who needed the help really loved it. The patients liked it even more. And we were able to document that it actually reduced costs. So that rather than having a long-term contract with this company, they were a fairly small company. We decided to merge with them. And so they are now one of the products that Aledade offers our practices. And we'll be looking to add on, like, how do we build concentric circles around the primary care practice, not replace the primary care practice, not take things away from them, not do things that they're not in the loop on, but support them to provide the holistic care that they want their patients to get.
And appreciate Sean Cavanaugh and Aledade's work there. We're certainly very cognizant, Mary, and working with you at Virtual We Have, and New Jersey Healthcare Quality Institute has been a leader in this area. A board that I'm privileged to serve on, Goals of Care Coalition, New Jersey, founded by Dr. Dave Burrell, a geriatrician in central New Jersey. So we work with Goals of Care Coalition, and again, our intent is to provide additional tools. We are working as well with another company, which I'm not sure if I've got the name right, so I won't mention it and misspeak, around this area, advanced care planning, compassionate care. We know that New Jersey had in the Dartmouth Health Atlas, and this is dated information because I would quote it, this was 10 years ago, the highest percentage of persons who died in critical care units in the country. That may not be true anymore. So I don't want to, again, that this was 10 years ago from the Dartmouth Health Atlas. So not where most people would choose to end her life or his life versus surrounded by family at home, dying peacefully. Sometimes the critical care is unavoidable, a major motor vehicle accident, something like that, I get it. But if you're end of life with COPD or heart failure or metastatic cancer, you probably would prefer to be at home.
Thanks again for both of you answering that. And Linda Schwimmer, I see, put some resources that Quality Institute has. We do sponsor a Conversation of Your Life program around the state with the Mayor's Wellness Commission, and that we also have some other resources on the website. I just wanted to maybe move into a couple of other, kind of more broad questions before we end. How do you both think the adoption of the alternative payment models will ultimately strengthen primary care and the system as a whole?
Well, I'll go first. I think I think we're all still learning a lot about how to properly structure alternative payment models and how to support practices and health systems in those models. But one of the things I like about them is they are built on a foundation of primary care, right? Like when Horizon works with us in our primary care, in our models in New Jersey, they're looking at what is the relationship with Horizon members with primary care. And I love just, even before you get to the financial aspects or the clinical aspects, that everybody instinctively goes to, well, it's got to start with a base of primary care. And I think that's a victory right there. It's not enough, but it's a great start. And so I do think if the future is that, then we're off on the right foot. The other thing I would say is, people often talk about, well, these alternative payment models haven't been delivering great results. Well, I'll tell you from my experience in Medicare, it's the only thing that's really worked is the Medicare Shared Savings Program, the ACOs. Medicare is not saving money in Medicare Advantage. We're actually spending more money there. But particularly in physician-led ACOs, Medicare is saving some money. And the question then is, how do we get more people, more practices, more physicians, more patients into these models? And then how do we continue to refine them? Whether you're on our side, helping the practices, Dr. Peskin's side on the payer, how do you better support the practices, refine the payment model? And I do think we're in that. What we could use is a greater sense of urgency. That, like, I think we're all rowing in the right direction, but how do we get the environment to say, this is inevitable? This is where we're headed. The faster you get there, the better. And that's where, when I answer the first question, the leadership of the state, whether it's the employer community, the governor, the institute, or some, group, all of them coming together, I think that would be fantastic.
Yeah, that notion of coming together, the African proverb, if you want to run fast, run alone. If you want to run far, run together. And our efforts are collaborative. Again, we're not perfect. There are physicians on this call that can point out mistakes we've made. That said, the notion of alternative payment models and keeping emblazoned the construct of better outcomes, which again is a big debate. Is hemoglobin A1C the end all be all? Probably not. Time within range is another one that is now bandied about with the continuous glucose monitoring people, but I digress about the medical industrial complex. And so we want to work with our clinical partners on the outcomes to measure and again, fewer is better, and then the whole notion of measures that matter. And then cost, honestly, we're at 19.7% of GDP, the highest we've ever been in 2020 in terms of, I think, $4.1 trillion. New Jersey's probably a little bit north of that in terms of our percentage of our state's GDP that goes to healthcare. So it's a fundamental issue for clinical organizations, for insurance companies, for suppliers, pharmaceutical industry, which is very big in New Jersey. And then hopefully we never lose sight of why what we're in this for, which are the populace. We've all got our examples of how the fractured system can lead to very great frustration. I've probably have 2 or 3 conversations a month related to that.
Well, great points there. One thing I think we haven't mentioned here, and I just wanted to toss in, is kind of the concept of how advanced payment models, if successful, will help our workforce development. That payment to the world is kind of a sign of value, and so we've been terribly undervalued. And if those in training, our young folks coming forward, see that there's value in what's being done, and a way to pay back their great loans, that I think it'll raise all boats as far as medical students becoming physicians and becoming family physicians, and other primary care specialties, and we'll be able to get APNs and PAs doing the same, and also even get more folks into the support roles for the practices. So I think that's an important aspect of this. We wanted to close here with just what elements of the alternative payment system models are most apt to strengthen our investment in primary care. I see the chat has been kind of blowing up with things about some of the aspects which are not strengthening, just the issues of connectivity of EHRs. I think the whole coding issue we just kind of mentioned a little earlier about HCC coding and how it increases administrative burden. So I think there are aspects that we hopefully can figure out as collaboration occurs in ways to improve on these issues. But are there other elements you think that are most apt to strengthen in the investment in primary care? And then I think the last question is also, I think there was a question about how do we see independent primary care surviving over the next 5 years to 10 years?
I think we see independent primary care surviving two ways. One is efforts like what you have going in New Jersey, which is like just shine a light on the importance of primary care, particularly independent primary care. Try to get them more resources, even outside of alternative payment models, just try to get them more resources. And then at the same time, in a parallel effort to move everybody into alternative payment models that reward better care at lower cost. And I think independent primary care will naturally do better in those models. So I think those two things go together. And how should these payment models evolve to make that happen? I think there's a couple things, and I've touched on some of these before. One, I think it's fine to provide this two-sided risk, but it needs to be calibrated, as we discussed earlier. It should be enough downside risk to motivate positive change, but not so much downside risk that anybody's practice is threatened. That doesn't accomplish anything. Quality measurement. There's been some chat in the chat about and even Dr. Peskin mentioned it, we have in other states, we've got contracts that have 37 quality measures. Primary care can't, 37, you can't have 37 priorities, right? That's the absence of a priority. So get it down to a parsimonious list of things that really matter and that primary care physicians can really focus on. And then the last thing I would say, and I apologize, this is getting a little in the weeds, but some of our contracts that we've seen around the country with payers, they reward people in alternative payment models for improving over the prior year. So grow less than the rest of the market. But it resets your base every year. We call this the ratchet. And once a group of physicians or a health system or any group has become, low cost relative to the market, it's hard just to maintain that. But if you're not getting any payment except by continuing improvement, that gets tough. So we need to balance what we call balance the payment for improvement and balance on payment for achievement being actual low cost. And I think you see these models naturally evolving there, but I think if we got there faster, it would be helpful.
Yeah, great point, Sean. So we moved away, as Mary and Peter and Lisa and others on the phone know, the web know, we moved away from difference in difference, which had the disrewarded the higher performers. So now it's budget based around total cost, and that's based on product. So if you have people that have a Affordable Care Act bronze, their costs are going to be less because they're paying a lot more out of pocket. That's just the way it is. Age, gender, risk adjustment. So those are the main, and then the budget is based on the cost in New Jersey, which are honestly quite high, and some inflation factor, which is where the conversation or negotiation about, we think it's 2.1%. Well, we think it's 4.6%. So, but we moved away from what Sean talked about, that disrewards folks that are improving year over year in a difference in difference model. And we also want to reward comprehensivists. So I learned about 12 years ago at a keynote speech at Rutgers Robert Wood that Dr. Emanuel gave the notion of comprehensivist versus partialist. I love that. So Mary and Peter are comprehensivists. No disrespect to orthopedic surgeons there who get paid a lot more. They're partialist. So if we're looking to look at how do we envelop more into that payment of comprehensivist, which includes things like sports medicine and maybe ultrasound, in-office ultrasound and things like that.
So I really appreciate you. You really gave us a lot of great wisdom and thoughtful answers to the questions. And I hope we can all continue this conversation along the following months and years. I think I need to now turn this over back to Linda or Claudine to close out the program, and do appreciate everybody's attendance. And we had a lot of great conversation, and this could go on for all day, but I think we're going to have to end soon. So
thanks everyone.
Thank you.
Yes, thank you. This was really fantastic, and it's so exciting to see all the participants from New Jersey and nationally, trying to see what New Jersey's doing and so we can learn from them as well. So I'd like to thank officially the Robert Wood Johnson Foundation and the New Jersey Healthcare Quality Institute and New Jersey Academy of Family Physicians for supporting part 2 of this virtual series on primary care as a common good. Another thanks to our incredible speakers for their contributions to the conference, and especially I'd like to thank the participants for joining us today and recognizing the importance of talking about valuing primary care. We hope it's been helpful to learn more about what investing in primary care is about and how other states are prioritizing it and increasing that investment in their states. And the Jersey Healthcare Quality Institute and New Jersey Academy of Family Physicians are hopeful that New Jersey will join with these states and prioritize primary care investment and primary care generally in all of its healthcare policy. So I thank you for joining us, and good afternoon.